Good morning, good afternoon, and welcome everyone to today's webinar, Betwixt and Between, the unique role of healthcare chaplains in promoting patient-centered care and medical decision-making. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. Some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions for our presenters by typing your questions into the questions box of the control panel in that same dashboard. You may send in your questions at any time during the presentation. We will collect these and hope to include them during a Q&A session at the end of today's presentation. With that, I'd like to introduce Jeannie Werpsa, clinical ethicist and research chaplain with Northwestern Memorial Hospital. She's also the co-convener of Transforming Chaplaincy's Chaplain Functions Research Network, which is sponsoring this webinar. Jeannie?
Welcome, everyone. I join Andrew in being thrilled to be with everyone here today. And I'm particularly pleased to be leading this panel session and presenting our speaker today, Dr. Robert Klitzman. As some of you know, I've done research on chaplains' role in medical decision-making and co-edited a book that featured case studies on this same topic. And so when I find a partner in crime, as it were, who's doing research in a similar area, whose themes resonate with what we lifted up, but puts a little bit different lens and twist on it, honestly, I'm just thrilled. So just really, not only did it confirm much of what we found, but I think continues this conversation and extends it into different areas of care, particularly among bioethicists, physicians, and other members of the care team. So thank you, Dr. Klitzman, for your work and for the rest of you for joining us today. So let me now introduce Dr. Robert Klitzman, is a professor of psychiatry at the Vagelos College of Physicians and Surgeons and the Joseph Mailman School of Public Health, and the director of the online and in-person bioethics masters and certificate programs at Columbia University. He's written over 170 scientific journal articles, 9 books, and numerous chapters on critical issues in bioethics regarding genetics, neuroscience, psychiatry, doctor-patient relationships, coping with illness, and other areas. I told you he had 9 books. I'm just going to lift up a few. The Ethics Police, The Struggle to Make Human Research Safe, When Doctors Become Patients, Am I My Genes? Confronting Fate and Family Secrets in the Age of Genetic Testing, among many others. Dr. Klitzman has also received numerous awards and fellowships for his work. He sits on several prestigious national ethics advisory boards and is a contributor, keep an eye out, to the New York Times and CNN. In addition to these formal accomplishments, let me add that Dr. Klitzman comes by his research interest in spiritual care honestly, as the son of a rabbi and as a psychiatrist with holistic perspectives on patient well-being. Today, he will be discussing the article he and colleagues published recently in the Journal of Patient Education and Counseling, Hospital Chaplains' Communication with Patients, Characteristics, Functions, and Potential Benefits. We're also fortunate today to have 3 panelists with us who will discuss the relevance of Dr. Klitzman's research on chaplain communication for our practice and our profession. Paul Gauchette comes to us from the University of Minnesota Medical Center. From his location as a palliative care and research chaplain, Paul will lift up what he sees as opportunities for future research in the area of chaplain contributions to patient-centered care and medical decision-making. Pamela Laser, manager for spiritual care at Cedars-Sinai, will focus her comments on implications of this research for chaplaincy education. And Doug Stewart will reflect from the lofty heights of his position as board member for APC and chair of the Research and Quality Commission about ways that we can leverage this research to make a stronger case for the value chaplaincy adds to healthcare. Finally, if you'll forward the slide, please. This is our structure for today, and please do remember that there will be an opportunity at the end for you to ask Dr. Klitzman and the panelists questions, and for all of us to discuss together. You don't need to wait until then to, again, formulate those questions. As Andrew has said, please type them not in the chat box, but in the question section, and we will field them to the appropriate person at the end of our section. Without further ado, Dr. Klitzman, all yours.
Great. Well, thank you, Jean, so much, and thank you to the other organizers. And it's really delightful to have a chance to meet you and talk with you today. And as mentioned, I welcome questions, and I look forward to the moderators' comments and my fellow panelists' comments. So I'm going to share my screen. And do you see this first slide? Does that come up?
Yes,
Yep.
it does. And Pamela, if you could turn your camera off, that'd be great.
Okay. So thank you again, and let me proceed here. Okay, so as background, as Jean mentioned, I come to this area for a few reasons. One is I mentioned I'm descended from a long line of rabbis, and I feel being a psychiatrist, I sort of got the gene, so to speak. And there's a lot of past research on doctors who became patients that has been done. And I wrote a book a few years ago called When Doctors Become Patients, in which I interviewed 75 physicians who became patients due to serious illnesses. And a lot of them said things like the following. They would say to me, you know, patients used to say to me, Doc, would you pray for me? And I'd go, yeah, whatever, and I'd poo-poo it. And then I became a patient and realized how important spiritual and religious and existential issues are, and have no training to deal with them. And that got me interested in the gap between the fact that physicians get very little training in this, and of course that's been increasing somewhat, which is great, but I think there's a long way to go. And I should add that doctors then respond in different ways, reassessing their beliefs, coming to believe in something, wishing they can believe in something, but it wasn't always easy for them. But there are a lot of questions that remained in my mind about how patients then interacted with staff around this. Similarly, I wrote a book a few years ago called Am I My Genes? Confronting Fate and Family Secrets in the Age of Genetic Testing, which I interviewed people who were at risk of different diseases, one of which was Huntington's disease, which is a devastating neurologic disease. Woody Guthrie, the famed singer-songwriter, unfortunately died of it. And if you have it, there's a 50% chance that each of your children will die of it. And so people would say to me, though, you know, I have HD because I have the gene, but why did God give me the gene? And why did God give my sister the gene, for instance, but not me? Or why did God give me the gene, but not my sister? And again, these large religious, spiritual questions, ultimately about why me, came up even about very medical facts, so to speak. I then did research for a few years and ended up writing a book called Designing Babies, How Technology is Changing the Ways We Create Children. And I did interviews with people who are undergoing assisted reproductive technologies, people who had infertility, and again, spiritual and religious issues would arise. People would say, well, I guess God must not have meant for me to have a child. Or they would say, you know, I want to have a child, and all my friends and family are saying, well, I guess God just didn't mean for you to have a child. And again, what do these issues mean? And again, there were other religious issues that came up about abortion and, quote, designing babies. People would try to go rabbi shopping or clergy shopping to get a clergy person who would support their decision to, they say, screen embryos or do other kinds of assisted reproductive technology. But again, religious, spiritual issues came up. And as you all know, attention to religious and spiritual issues, as I mentioned, is increasing slightly in med school, but it's often insufficient. And about half of doctors, 48%, feel uncomfortable with religious, spiritual issues. 44% feel that patients will be uncomfortable if doctors raise it. 70% of dying patients, as you all know, want their doctors to ask them about religious beliefs, but only half of those get it. And those who get it, regardless of whether they want it or not, are much more satisfied with their care. 72% of cancer patients said the medical system supported their spiritual needs minimally or not at all. Nurses tend to be more aware of these issues than doctors, and chaplains, of course, can play very important roles, but only see limited numbers of patients in many institutions. And of course, this varies by institution, but at least in one study, only 4% of ICU patients saw a chaplain. So I realized there's a lot of broad questions that I thought would be important to study. How are patients of varied background and conditions confronting these issues? What challenges they face? How are chaplains addressing these issues? What challenges do they face? And what implications there are for future education of physicians, nurses, chaplains, patients, families, future institutional other policy and research. So I did a study of chaplains that I'll talk to. And again, I've done other studies, as I mentioned in the past, that I have informed my thinking, studies of people with HIV, substance abuse, genetics, assisted reproductive technologies, etc. So for the study of chaplains, I interviewed in depth 23 board certified chaplains who I recruited to the Association of Professional Chaplains and word of mouth. I conducted 1 or 2 in-depth interviews each for about an hour each, and the content was coded by myself and 2 other coders. And I apologize for the small size of this, but just so you can see overall, there were 13 men, 10 women I interviewed, 18 were Caucasian, 3 African American, 1 Latino, 1 other. The average age was around 63. They were mostly from the Northeast, but not only. Excuse me, 6 were Protestant, 4 Catholic, 6 Christian, not otherwise specified. Excuse me, 3 were Jewish, 3 Muslim, 1 Buddhist. 10 held masters, 5 doctorates, and others. And they'd practiced around 18 years overall. So as you all know, briefly, chaplains play key roles. They're increasingly denominational, giving prayers or good wishes, but they're often under-resourced, operate in a separate world from doctors. Often the doctor will enter the room and the chaplain leaves, or the doctor leaves the room and the chaplain enters. They're not included on rounds. They feel marginalized, etc. But what struck me that also came out in what I wrote the paper about that and that Jean led to Jean inviting me to speak with you today is about the communication with patients. I thought I'd read a few quotes from what I found and then talk about sort of in a more systematic basis what some of the themes were.
Dr. Klitzman,
Yeah.
I'm going to interrupt you for a second. Can you put your slide into slideshow so that we can see it better? Right now it's smaller. If you put into slideshow, current slide, then maybe this, especially this important slide. There we go. Perfect.
Okay, there you go.
Thank you. Great.
Okay, so I just, I think just stepping back, I think chaplains have relatively unique characteristics. They may have relatively more time to spend with patients and a lot of harried providers. They have a less rigid and less medicalized agenda often. They can draw on religious traditions of aiding the most vulnerable that many of them did. So they really, as will come out in some of the quotes I'll mention in a moment, I think they are in a position where they can stand back and understand patients' points of view in a way that other providers may not be able to do as much. They can gain patient trust, offer different perspective, be relatively open-minded, etc. So one thing I found is that they could obtain key information from patients and families that can assist with diagnosis and treatment. So here, this is one example. A chaplain, for instance, talked about a 12-year-old, I'm at the hospital, so there is silence here, who accidentally had neurologic damage. The chaplain told me the team would show his family, the patient's family, his scans saying his brain has no function. But the family just kept saying, you've got to keep trying and do everything. He's going to get out of this. It was causing a lot of animosity. Finally, this is the chaplain speaking, the chaplain talked with the mother. This was shortly after the Terry Schiavo case. The mother said, this week before this happened, the Terry Schiavo case was on the news. And my son said, I don't understand. Just because her brain doesn't work right, they want to throw her away. So the mother had a mandate from her son. She was never going to throw him away just because his brain didn't work. I shared that with the medical team, that his mother is never going to shift from her thinking. This is her mandate from her child. We have to find a way to align with her. We're just causing her more anguish and yourselves more stress. So we were able at least to align with her and reduce the stress for her for the rest of his time with us, which sadly wasn't long. Once you understand why someone is thinking the way they are, where they're coming from, the staff are able to accept that more. So I thought that notion that chaplains, I think, are in a position where they could understand, quote, where the patient's coming from, so to speak, is extremely important. And I thought that was something that I had not seen in the literature, the wonderful literature by George Fischette and others who've working for many years, doing wonderful research on chaplains. I thought this was sort of an added element that I'd not seen there. Another issue was obtaining information to help with patient decision making. So this is another case. Another family, this is another chaplain speaking. Another family appeared to resist having DNR and goals of care conversations, causing tensions and frustrating the medical team. Every time the patient's situation looked very dire, the patient, she, a female, would open her eyes or squeeze her hand. A chaplain finally called the patient's daughter. So in other words, a chaplain got involved and called the daughter, and the doctors were pulling their hair out saying, you know, this is just terrible. We can't get the family to move on this and make her DNR. So the chaplain told me that she called and said, quote, "I'm from spiritual care and just wanted to see how you're doing. I know your mom's been in the hospital for a while. It must really be hard." The daughter was really receptive and said, "Yes, I don't think she's going to live much longer." I asked, "Well, what's the hardest part for you?" She said, "I don't want her to die next week on my birthday. She always seems to get sick right before my birthday." So the family was very realistic about her mother's condition and had thought about it. This is the patient's daughter. I said, "What do you think your mom would want?" Quote, "She made me promise not to put her in a nursing home. How do you think she'd feel about being in the hospital for a while?" "She wouldn't like that either. I just don't want her to suffer." And the family then agreed to a realistic plan of care, which surprised the patient's doctors. The attending actually called the chaplain and said, "What did you say to her to get her to change her mind?" So again, I think understanding, you know, not just, oh, the family says no, but why the family's saying no, you know, I don't want her to die on my birthday, et cetera, in part. I'm sort of bouncing around here, but so also there's another example, obtaining information to assist with diagnosis and treatment. So this is another chaplain. A patient came in for intense GI pain and the doctors did every test and found nothing and sent him home. He came back and the same thing happened again. He returned a third time and said, "You're wasting your time and mine. You're not going to find anything, but it hurts." I went and heard his story. I was the first one to sit down and just listen and not try to diagnose. I asked, "When did the pain start?" He gave me a specific date. "What else happened then?" He paused. "My wife died of cancer. We had struggled for a year. Then my daughter got cancer and passed away." He wept. So the chaplain told the team, which arranged for psychotherapy and discharged him, and he never returned, basically, to the hospital with the GI problem, at least. So again, I think finding out that kind of critical information that I think helps with medical care in a very direct way can be very helpful. Conveying providers' points of view to patients also. So this is another chaplain. This is quote, for brain dead ICU patient, the family still wanted everything done, and the family and staff became very polarized. It was just a lot of very tense moments in family sessions, and the chaplain was there finally and said, finally, quote, "I said, look, I hear how much of the family, look, I hear how much you love your mother. But I also hear that the staff here also cares very much for your mother. So everybody's trying to do the same thing. We're all coming at this from the same perspective." Suddenly, when love was introduced, the whole mood in the room shifted. It became, okay, we've got some common ground here. We're not on opposite sides of the fence. That was very helpful. There was no more conflict about it. Families say, okay, as long as the staff knows that we just need more time. So again, illustrating the important role. I'll read one or two more of these and then go on. This is another case. This is another chaplain. A young African-American woman came in multiple times for pain management, was not being evaluated and getting the care she needed. She was being framed as a drug dealer. I connected with her and was able to create a respectful bond. Luckily, I had a very good connection with a maternal fetal specialist. We'd worked together on the ethics committee. So I called him and he came in. We found that she had a kinked bowel, which can come and go and get stuck. The patient ended up having a profound infection in her gut because it had leaked, but the team had not done certain tests, assuming she was just drug seeking. A chaplain's role is very powerful. We can see people beyond labels. And I thought that was also very powerful because physicians, as a physician, we put a diagnosis, which often becomes a label on a person that may be helpful, but also can limit our vision of the patient more broadly, for instance, and think in terms of other categories. Another one here was a man was in a car accident and the staff, he was covered with, he had no identification with him and was covered in tattoos. The staff treated him as though he was drugged out and had OD'd. They automatically ordered a drug test. They didn't even really want to touch him because he could have anything because of the tattoos. I said, my son has tattoos all over him and a PhD. I know about people who have tattoos. Sometimes tattoos tell a lot about a person. and we looked, maybe his name is on his body. We found his name. He happened to be the chair of a department at a nearby university. He had never touched drugs in his life. So this prejudice people are judging. Their biases against handicaps, sexual preferences, the way you look, fat shaming, etc. So again, I think these are ways in which I was struck that chaplains can, as on the slide here in the middle box, convey information from families and patients that can assist, convey providers' points of view to patients and families. They can mediate conflicts. There's some other quotes about that, serving as go-betweens. They can overcome staff biases or labeling of patients, providing fresh eyes. Often these are vulnerable patients who are voiceless, so to speak. Particularly, there are other cases that I talk about a homeless patient, for instance, or people with addiction, the case I mentioned, for instance. They can help staff to reframe views. They can pursue and encourage psychological interventions. There was another woman, there's another quote here. One patient, the staff had little tolerance for this one patient because they felt she was drug seeking. There's another patient. I asked, why are you trying to kill yourself? She looked at me and said, you have no idea what I'm going through. A floodgate of tears came, but it was a breakthrough. I said, tell me about those tears. She said, my tears are my pain from suffering, my tears of anger, of nobody understanding. I just get mad. There was a lot of domestic issues. Her husband had abandoned her. I asked whether she'd want to go into inpatient recovery. She said yes. What baffled me was that over 3 or 4 years, she had been a frequent flyer at the hospital, but no social worker, psychiatrist, or other staff had ever talked to her about drug treatment. I found a drug treatment center for her. That was 6 years ago, and she's been clean ever since. So again, I think people with addiction may face particular biases for the reasons we've been talking about. And of course, I think often psychotherapists are unavailable, social workers don't have time. So I think there's a few implications here that I think hospital administrators, physicians, and others should more fully recognize and appreciate, I think, how chaplains can play these kinds of roles. I think chaplains' education, again, I'm not a chaplain, so I defer to you all, but I think could potentially help chaplains in recognizing and performing these roles. And there are, I think, skills that can be taught around this and awareness that this can be important. Educating medical staff about chaplains' potential roles and approaches and potential interactions of sort of medical perspectives. I think for research, and others will talk about this on the panel today, but to look with larger samples. This was a small sample of 23 chaplains, but how often, in what ways chaplains have formed these roles, what types of information they can gather, maybe what questions in particular can help elicit it, whether certain chaplains do this more than others, if so, why, maybe related to differences in training, skills, perceived roles. Some chaplains I know have had more exposure or experience or training with psychotherapy that I think may be helpful in some of these skills, etc. And just again, context, I think a lot of doctors don't know what to do when these issues come up. They, I think, should refer to chaplains more, but they should also be prepared to address in some way these issues or be sensitive to know, especially if there's not enough chaplains to go around, when it would be appropriate. And so I just to give an example, one doctor I interviewed told me that he was wheeling a small child into the operating room, and the feeling was the child may not survive. And the family said, "Doctor, will you pray with us?" And the doctor said no, he was a different religion, and left the room, and afterwards felt very badly. I mean, he could have said, "I'm happy to stand with you," and he was basically an atheist, and I don't remember the religion of the family, but you get the idea. And I think there's also ways in which doctors and patients talk past each other. So the doctors will say, "How are you doing?" Patient will just say, "Well, I just hope God will get me through this." Doctor will say, "Well, did you make your follow-up appointment," for instance. So I think being sensitive to this kind of language is something I think we chaplains and doctors could train doctors to do better. More awareness. I think also what patients may be saying when they raise these questions. When patients say, "Will you pray for me?" they may be asking really, do you care about me? Do you? One other doctor I interviewed said that he was treating a Muslim patient who was a recent immigrant, and said to him, "Doctor, do you believe in God?" And the doctor didn't know what to do, hadn't thought about the issue, and said, "Well, I do, but I'm Christian." And the patient said, "Well, I can, thank God you're a man of the book." Since of course the Bible and the Quran or the Islam sees Judaism and Christianity as part of the same tradition. So I think also one thing I found is that doctors are not taught to communicate well in general. I mentioned the earlier book I did on when doctors become patients, and one doctor, for instance, told me that as he was a surgeon, and before he underwent surgery himself as a patient, he told me that his doctor said to him, his surgeon said to him, there's a 5% chance you may die tomorrow in the OR. And this doctor told me, I couldn't sleep that night. And only afterwards, he said, did I realize my doctor could have said, there's a 95% chance things will go okay tomorrow. And those two facts, he said, are statistically the same. I never realized, even though I've been a surgeon for 20 years, that they have such different emotional resonance. There's a picture of Epidaurus, which I recently visited in ancient Greece, which is the largest intact theater in the ancient world. But what I hadn't known until I've went there, was that it was actually part of a hospital. That there was on this grounds, it was center of healing, and there was the theater, there was a hospital and a temple. And they were all together in this marble enclosed compound. I thought that in some ways is an ideal of integrating, not just have a hospital on one side and a temple and a theater somewhere else, but bring them together, I think, is a lot of advantages. So in conclusion, I think that chaplains have a lot of benefits that I think could be explored more and promoted more. I think could be enhanced in training through psychotherapy. Arguably, and this I defer to many of you, it may require chaplains learning more about medicine or more about some of the kinds of ways they can contribute, but I would argue that I think that's something we're thinking about. I think obviously there's a lot of attention that understandably has been given to assessment, needs for assessment, what's being assessed, patient satisfaction. But I think there's questions, what's not being assessed, some that can be gained perhaps in terms of in various ways. But I think meeting other needs as well, and particularly sort of communication needs and the content of information, I think is something that also could be assessed that would help. These are some of the books I mentioned that you might find of interest, and I'd be happy to answer any questions. And again, thank you very much.
Wow, that was a very thorough, quick, and packed description of your research. I know there's so much more there, and our respondents will hopefully lift up some questions for you to consider, and then our attendees as well. So I'm going to ask our panelists to put yourselves on camera, and then Dr. Klitzman, if you could unshare your slides, your screen.
How do I do that?
I have no idea.
Change presenter?
I'll make myself the presenter, Dr. Klitzman.
Oh, there you go.
I just made it.
Thank you, Andrew. Save the day yet again. Okay. And Paul, we're going to ask you to begin by talking about opportunities for research, kind of what you know is going on in chaplaincy right now that overlaps with some of this research as well. So.
Thank you, Jeannie, for organizing this, for putting this all together, for the invitation to be a part of this. Dr. Klitzman, thank you so much for your work in putting together this article, this PowerPoint, for joining us today and to have this conversation. And thanks to all the colleagues and people who are invested in this work of spiritual care together. Yeah, like Jeannie said, I'm kind of moth to a flame with some of the things that you talked about and have a lot of areas of interest in research. I'm just going to highlight a few of them, I think, especially from reading your article a few times, that have been very helpful. First, I'm really fascinated, Dr. Klitzman, by this sort of liaison role that gets lifted up. That's my word. That you talk about how you heard chaplains talking about the sense that we hear things that maybe other people don't hear, that some things get uncovered, and that we share that with the team. And then I also heard that being these liaisons, we kind of have these interactions daily with our intensivists, with our psychiatrist partners, with our, the NPs, the physical therapists, and that somehow in this like holistic circle of care, we communicate this together. So that role for me is fascinating. And the biggest question for me that I love to explore with people when I get to talk about chaplaincy is, are we clinicians? And if so, what does that mean? So that's one area I would love to, wonder more about. That leads to like a second area. It certainly shows up. I think highlighted the Brittany Lee article about documenting presence, where chaplains talk in this coded language. What are you saying? And we totally agree with you that work needs to be done. That one of my favorite books I read years ago from Lisa Leahy and Bob Keegan was How the Way We Talk Changes the Way We Work. And I think there's an aspect of, we chaplains have our own talk, but how is it that we talk to the Dr. Klitzmans and to the other folks on our team so that these really valuable messages as this liaison kind of clinician get shared with the people that we work with. There was a study I got to be a part of, and we asked palliative non-chaplain clinicians about kind of what they want in our progress notes. The thing that was most salient was we wanted to hear about decision making, which I know is one of the areas for this webinar. And the cool thing about that for me was we're not necessarily hearing it from you chaplains, but there's this potential, like there's this potentiated, we know that you kind of hear things that we don't hear, and that you kind of get into these stories and you hear this past, present, future aspect. So that's a second area. A third area for me is really you bring up time for me in the article. The chaplains have time, and perhaps even more so than other people. And one of my the articles I like from a guy named Wilf McSherry out in the UK is in the discussion section of the paper, he writes it as clearly as the most important contribution a chaplain makes is time. And to me, like, what does that really mean? To unpack that, that would be a fun research piece. And then the related to all of these is the last one, which is who shows up. So we've all had this experience as chaplains where like you're exactly the person I wanted to talk to, or like you're going to hear it differently. I've had the experience where I'm dressed like this, where I go to see a patient and they're like about 4 sentences into the conversation and they'll say, "Who are you again?" Because my wardrobe communicated something that just said above and beyond. And so they want to talk to me about Lasix and octreotide and whatnot, and that just wasn't within my scope of practice. But those are some areas for me that are really interesting based upon your important work that you did with your colleagues, and I appreciate you sharing that with us, and look forward to talking some more.
Thank you, Paul, very much. Anything you like, one comment or response you want to pick up on at this point, Dr. Klitzman, before we go to our other panelists?
No, I'm all great comments. Thank you.
Yeah. One article that I was also thinking of, a research that's been done, is Lexi Tork's work looking at chaplains as navigators in the ICU. And I think both of you point to this, the importance of understanding the language, the timing, the structure, the demands of certain professions, because why that role failed was not because they didn't speak the language, they didn't get the schedule and the rhythms, and they were perceived to be outsiders and not respectful, right? Whereas they had all this knowledge and they were positioned in this role and they couldn't make it work. So something's still lacking there, yeah. Go ahead, Pam, why don't you jump in?
Sure, thanks, Jeannie, and thank you so much, Dr. Klitzman, for this really incredible paper. I really appreciate how you have laid out, chaplaincy research so often speaks about those basics that you point to in your paper, the kind of providing pastoral presence, active listening, demonstrating care and concern. And what I really appreciate about this particular paper is that you lift up this, how the content of those interactions with patients provides vital information that the rest of the team really needs. And so for me as an educator, the challenge for educating healthcare chaplains, from your paper, of course, there are many challenges, but I think the top 3 that came out for me, the first one was the chaplains need to be educated to know what information about the patient is helpful for the rest of the team. We get a lot of information. So saying, we have really intimate conversations and a lot of information comes up is not a secret to any chaplain. But I often find the chaplains are not necessarily sure which information they should be passing on to the rest of the team. And so kind of a subset of education there would be learning about the roles of the other team members beyond the basic assumptions that we make. What are their specific interests and needs vis-a-vis the patient? Because that would help the chaplain to then know this is important to tell the team verbally rather than just put it in the chart note, or how do I communicate that in a way that is clear and understandable, both written and verbally, to the rest of the team. So that's the second point for me also with education, is the vital role of knowing how to do interdisciplinary collaboration and communication. This involves, I think, so many different levels. It's not just communication skills, but also often conflict management skills might come in there. But I think that even a subset below that, and you can maybe see how I think, is that chaplain formation needs to really help chaplains recognize, value, and articulate the, as you say, the unique role that they can play in patient care and staff care, in order to effectively claim their professional authority in an environment that does not automatically recognize their authority or value what it is that they're doing. And this also can be really hard to learn because it can go against many chaplains' valuing of humility and the fact that many chaplains are also introverts. And so for me, this is a formation piece. There certainly are skills that can be learned, but there's also a deep internal formation piece that needs to be learned in order to serve our patients and the teams that we're on. And then finally, from what I saw in your paper, chaplains need to be trained to be educators and advocates for what they do. So it's not enough that we simply know what we're doing, but we also need to constantly be educating the people we're working with about what it is what we do, what the value of that is. And we need to know that education, it's not just a one and done, it needs to be a continuous thing that we're doing, and it needs to be specifically tailored to the different disciplines and teams that we work with. So anyway, those were the three major takeaways that I got from it. I highly agree with you. I think more education in terms of psychiatry, in terms of medicine, very, very valuable. And so I think my final takeaway piece from this is that, you know, when we think about chaplain education, we often think about, you know, CPE and those 1,600 hours. But clearly, this is far more complex, and the environments that chaplains find themselves in are becoming even more complex. And so I would also love to see ongoing specific education for chaplains, even once they become board certified, to be able to gain these interdisciplinary skills that are the things that are best going to serve our patients and the teams that we work with. Thank you so much for a really excellent paper.
Thank you, Pam. Really appreciate that response. One of the things that I wanted to just add to your comment was, in the study that we did on chaplains' role in medical decision-making, those who were more likely to be integrated into the team actually were more experienced. They had 5 years and over. And I think that, again, whether there was intentional education for them during those 5 years or not, somehow being in the milieu, learning the language, getting known, claiming their value, and I think claiming some more authority really made a difference, because the younger ones, again, did not come out, as you say, out of CPE with those skills. So it'd be great to develop curricula actually to promote that ongoing development. So.
Exactly. I noted that most of the chaplains, as you said, I think Dr. Klitzman, were the average age was 63, right? And so we can't wait for people to get that far into their field before they can do this work.
Yep. Yep. Finally, Doug Stewart, you're going to speak to us from, again, the perspective of what do leaders need to do to really make a case for chaplaincy value, again, drawing upon the work of Dr. Klitzman.
First off, love the paper, Dr. Klitzman. There's some stuff I've done in my own research on economic value for chaplains. I use the term integrated chaplains in the ICU, and it really echoes the stuff that I saw. So you're spot on the things that need to be happening, and working with the physician, the nurses, and the staff. One of the most important things is I'll sit down and say, you need to have 3 friends in the hospital. You've got to have physician leaders who say chaplains are valuable. You've got to have nurse leaders who say chaplains are value. And then the tough one is you've got to convince the CFO that chaplains are valuable. And so one of the things I always say, there was a lot in there that had great patient care. We improve patient care, but we also need to quantify when you have somebody who is sitting in an ICU, an event, that's $4,000 to $5,000 a day at cost. You only have to work, and families are saying, coming to terms that we're helping them come to terms with what's going on. And we're reducing length of stay, providing the right care for the patient, providing the right care for the family. We need to, as chaplains, I know we don't like numbers, a lot of us, being able to quantify that, because those are the numbers you take to the CFO and say, you know, here's some things that when you're looking at this, we're saving you a lot of money and giving you better care. And when the physicians, the nurses go to the CFO and say they're doing good work, and they're saving us money, it's so important. And I saw that in your paper. We to really be able to take some of that economically and leverage that research, and then, you know, do some more publishing on the value chaplains bring to physicians. And that is an education piece, both from chaplains having to be able to stand up and say, we add something, and then working with physicians and I don't want to say selling it, but making a convincing case that we add value to them. I know our nurses often find significant value in us and the work we do. And my own anecdotal evidence, I saw a lot in years with decision making. I think chaplains can approach from a different perspective, kind of relational, spiritual, emotional, that you don't get from other clinicians, that really are can help guide the other clinicians in helping them make decisions and help families make those decisions. So brilliant. You hit a lot of the key points that we need to see.
Doug, one thing I want to maybe put back to you and to Dr. Klitzman is, we talk about chaplains having all this time on our hands, right? This is the important thing of being able to slow down the clock, being able to sit with folks after meetings. But the truth is, at least in the work that we did, we found that that was the biggest barriers to chaplains actually being integrated and being able to do exactly what we're talking about today. So it almost seems like we're in a catch-22 a bit, right? Chaplains have this that we can do, but yet we're staffed in such a way that you're holding the pager, you're paged out of the ICU family meeting because you're on call. So I guess I'm wondering also from our professional organizations, I mean, how do we begin to think about staffing ratios, about, I don't know, a better positioning chaplains to do what they're actually trained to do well and contribute?
This has been one of my themes the last probably 3 to 6 months, because I even look inside my own system. My hospital has a good staffing ratio. Some of the other hospitals don't. We are able to do some things that the other hospitals aren't, and we're getting anecdotal evidence that, well, they don't do a lot, so we don't fund them. It is a nasty circle. We've been fortunate to be staffed fairly well, and then they've seen we're adding value. So you really have to do a lot of education and put the case forward to the physicians, the nurse leaders, and ultimately the CFO, that we can add value to the clinical setting and to the financial setting. Because the CFO will give you money if you can sit down and say, you give me enough for another chaplain and I can give you a 2 or 3 times return on investment. They'll make that.
All right, great, thank you. I'm going to ask Dr. Klitzman if there are pieces of what our panelists have said that you'd like to respond to, pick up on, and I'm going to monitor the chat box here as well.
On the last point, I think coming up with standards or benchmarks for the field, saying either, here's hospital X and they have, 1 chaplain for every 300 patients or something versus one for every 600 patients, and they were able to do this. So in other words, I think if you establish, one would be across institutions to get, and again, there may be such data out there on, my sense is some of the challenges are, cancer hospital may have more chaplains per patient than does a tertiary care center may have more chaplains per patient than does a primary care hospital. You can break that out and say, this is the range, or certainly if a hospital is below the average, you could say, look, the average across 100 hospitals that have been surveyed is, one chaplain for every X number of patients, and we're below that. You can say we need to be up to par. So that would help some institutions if they're below the average. But I think if you could demonstrate in any institution, that kind of return on investment, or have stats on that, I think to share that with other colleagues, I think that would be powerful. If you say, look at Hospital X, they actually did the study and they found X, Y, Z.
Don't you think it's harder to quantify? And I'm not sure I want to, what actually is at the heart of your work, though, which is, which I guess I struggle a little bit with the quantification, because it's like you're talking about patient-centered care. You're really talking about these moments that we get to know who this person is, the narratives that we use, that we bring, the communication skills. Does that shorten or lengthen stay? Who knows? But is it the right thing to do, and is it really good care for our patients? Does it actually probably lead to better medical outcomes, better care that's aligned with what patient preferences and values are? I guess that's kind of where I want to go back to you, which ties back in with some of what Paul has been thinking about, and Pam in terms of education as well.
Yeah, so I agree with you. I mean, there's been good work, Dr. Fitchett and others on sort of quantifying various things. And I was struck how much there was, which is important, but then drilling down, as I think Pam said, there's sort of the content of what gets communicated, I thought could sort of add to that or complement that in a way. I think qualitative data can also be legit. I mean, I think you could take articles like the one I wrote and show it to the CFO or show it to administrators and saying, look, some of this may not always be quantifiable. There's a lot of things that are not. Psychotherapy is notorious that it's not really quantifiable, or a lot of it isn't. Or if you do quantify it, it's not going to be the most important things. But people agree, that it's often very helpful, particular things, et cetera, et cetera. So, if you can quantify it, great. It may not always be possible to quantify, or may be complex because of other situations. There was the article, I'm going to get this a little wrong, but on whether it decreases, seeing a chaplain change, well, even with the satisfaction data, right, that it turns out it's complicated because the patients who a chaplain may see may be those who are sicker and the patient dies, and so the family may be less satisfied. That doesn't mean that the chaplain didn't help. It just meant, look, the patient died, and that's why the chaplain saw the patient, and, would have been even worse. So again, it's hard, there's complicating factors in all of that. I do think in terms of what medical information to know, I mean, I think that's a piece that could be studied. In other words, if it will affect the understanding of the cause of the disease, if it will affect possible treatment. I mean, I think those are why the disease happened and what can be done to help it, whatever the disease is, addiction, et cetera. I think those are pivotal points that, data can help with. Data gotten in the form of interviews, of talking to patients, can help. And back when I went to med school, even then it was fading, but the notion of, a good doctor would spend an hour with a patient to really know that patient. Now, of course, the average visit is, 11 minutes or something. So it's kind of, we're reduced to checklists. But I think chaplains can, and so a lot is missed about that could be relevant. So I think to train one's ears and to know cognitively, what are those, am I hearing things about why the disease started, or about treatment, or things that they may not tell the doctor. I mean, two other areas I know when I did the work on when doctors become patients, of few doctors would say to me things around mental health issues, for instance. So these doctors would say, you know, my doctor would say, how you doing? I'd say, oh, not so great. And it finally took, you know, 6 months and 6 visits for me to say, actually, I think I'm depressed and may need treatment. And these doctors would say, well, if I have that much shame in talking about depression to my doctor, I can imagine my patients not wanting to talk about it either. So I think there were mental health issues, for instance, that I think a lot that get missed, underdiagnosed, that chaplains can listen for. And this gets back to, I think it was Paul who mentioned the question about are chaplains clinicians or not, and what that means. You know, my first instinct is to say, I think it's a liminal, so to speak, position. You know, it's an in-between position, but chaplains are partly clinicians. I mean, you work in a clinic. I mean, you know, you're dealing with clinical care. So I think that in some ways you are, but you have on the one hand, wonderful, but also challenging position of being, as the title of the panel today, betwixt and between, right? So and I think having that insider-outsider status can either be frustrating or wonderful or both or some mix. But I think to figure out how to embrace that and say, okay, let's have the best of that, like the best of being the insider and the best of being the outsider, how to, you know, frame that and see that as a gift rather than a deficit, you know, could be helpful. Or to say there's, you know, right. I mean, I think that's, you can almost imagine if there's like a Venn diagram, you're sort of in the middle, you're partly this, partly that. So, but that's okay. I mean, I think, you know, and my sense is, you know, social work has had a similar set of challenges in the past where they've had to learn how to manage the situation, you know, manage the fact that they are, you know, not the center of the clinical team, not completely extraneous, sort of how do they leverage what they have? And it might be worth communicating with social workers or with looking at that literature of how they have sort of, you know, worked to understand. Social work training, as I understand it, trains people to, you know, how do you manage situations like that? And that might be helpful.
Go ahead, Paul.
Yeah, I appreciate your comments right now and the other panelists, Jeannie, what you've been naming. There's something also about the paper that I love, and perhaps you name it, but like sort of a meta in the middle of all this for me is time is almost like a proxy. It's like because of time, the sense making happens. The utter sense of a person leaning in, like, are you really listening? Do you really care? And if so, these aspects that you lift up with these really important quotes get generated, and these moments of love and compassion. And I'm a human being amid these trajectories of illness where I'm having to reconfigure my life, and this is tragic and this is hard. And again, you really care, and you're in that chair and you're not leaving. Makes a significant difference. And that's the piece for me where time is, yes, very important, but it's also, for me, it's like, well, but what's behind that lens, or what's behind that, like, what does that mean? That would be really interesting to explore.
I would say the amount of time is also relative. Chaplains are stretched for time as everyone else, but relatively speaking, I think you have more flexibility in your time, perhaps, or some chaplains do. Sorry, Doug had his hand up there.
Well, and the investment in time up front, right, will pay off in the long run. So I was thinking when you were talking about what medical knowledge chaplains needed to know and where they could make an impact, think about adherence, right, of medical adherence. If chaplains are able to find out, for example, that the patient hates taking medications, that they prefer once a day, that they're just kind of, that they can't in their local neighborhood get the medications they need, that they have somebody at home that they need to support, which is why they're only getting half of their medications. I mean, all of these facts that are embedded in these narratives, right, of people's lives that could actually make for better adherence down here. You could save a lot of money. You could save a lot of time because that patient's not going to wind up back in the hospital in 3 days, or not going to be, you know, have as long a time spent in the hospital. So Anyways, I think it'd be really interesting. I agree to think about the time factor. I had one other question I wanted to put back to Pam and to Dr. Klitzman, which has to do with something that has really challenged and troubled me for a long time in chaplaincy. And you named it, Pam, which is many of chaplains are very introverted. They don't claim this knowledge that they have, this authority, and sometimes they don't have it, but it becomes, again, a deficit. So I'm wondering, again, the question is, Bob, from where you've sat, from the interviews you've had, how are we going to help chaplains overcome that and understand that they do have a place at the table and that they're really needed, and mobilize them to be proactive and to stand up and speak up and share this knowledge in meaningful ways, because we know it makes a difference, but there's something there, there's a barrier there. I don't know if it's formation, education, educating physicians.
So I think there are multiple levels at which change could be helpful. And I think that you can teach skills. So for instance, one doctor I interviewed as part of the other study said that was not the most socially adept person, so to speak, might have a little bit on the spectrum, so to speak, but he said to me, when I went to see my doctor, he kept me waiting in the waiting room for 45 minutes. I was driven up the wall. So I said, have you ever kept a patient waiting? I don't know. I never thought about it. He said he then at a certain point says to all patients when he starts out, I'm sorry to have kept you waiting. He says, I don't know if I kept them waiting or not, but I just say that, and it sort of melts the tension in the room that I didn't even know was there. So I think there are things that you can train people to ask and say, that even if that's not quite as a checklist, but I mean, checklists have some benefits. That you don't want to just be a checklist, but I mean, there may be questions, probes that may get at some of this stuff, and I think people may not naturally be chatty, but you could still train. This is an important part of your role. If you give them a script, they could, or have them come up with a script that feels comfortable for them as a way to ask questions. I think are ways of doing it.
Pam, any thoughts?
Oh yeah, because I think this is such probably one of the core issues in training students that is so challenging. There's this sense of like the staff are so busy, I'm interrupting them in the middle of the day, they're not very friendly. But I think some of the things that I've seen that can really help, and it's obviously not for everybody, is hearing from staff themselves how much they want to know what it is the chaplain is picking up, and that they value that, I think can shift a little bit of that internal frame of like, I'm bothering these people, I don't have anything important to communicate. When the team is saying it is actually important and we do need to know what this is, I think that can help. I think the other side of it also, that for many can overcome that, I want to say shyness, introversion, and values-driven humility, is understanding that this information is actually vital for the patient's well-being. And so when we understand this is not just about me, this is not just about the team or somebody who may be treating me in a rather offhand way, this is actually really important for the patient's well-being. And so I think that can also propel someone forward. And then once we start getting to know our team members as colleagues, as people, as human beings, which goes a long way. We make all of our students do tea for the soul and things like that, so that they can start getting to know their colleagues as people. It becomes easier to have those conversations with them about the things that are going on with patients, or ask them, what is it that you want to know? Is there anything you would like me to communicate when I go in to see this patient? Or I'm hearing the patient saying this, I'm seeing this other thing in the chart. There's some missing information here. But anyway, it's really difficult because it involves a formation process as well as an information process.
Mm-hmm. Thank you. I'm going to give Dr. Klitzman the last word. We have 1 minute. First, actually, before you take the last word, I think we should all thank him for his work, his interest and support for our profession. I think that is that speaks for itself. If we're talking about value, right? Here we have a physician saying, we need to hear from you all. You guys have valuable information that we all need. And for joining us today, of course, and being part of this conversation. Dr. Klitzman.
Well, just thank you in return. I think you're all doing great work and want to encourage you. And I think showing this paper others around might be helpful. And I think, again, I thank you for inviting me to speak. And I think all the attendees, I hope, got something out of it. And I welcome people's thoughts on these issues. If you want to contact me, please feel free to do so. Thank you.
Thank you. And I see Andrew is going to be posting some forthcoming webinars. And there you go. Oh, no, that's not it yet. There we go. QR code for forthcoming webinars. Oh, there we go. Spiritual care and finance. We were just touching upon that. Many interrelated topics today. So again, thank you all. Thanks to our panelists and to those who joined us. This is recorded, and I know you'll have access to it if you'd like to in the future. Thank you. Have a good rest of your day.
Thank you.
Thanks, everybody.
Thank you.